how a large language model generates a response. Before we talk about how large language models generate a response, it's important to set expectations. These systems do not think, reason, or understand. They're trained to generate language based on patterns in data. So as we walk through this process, the goal is to understand how the way these systems respond explains both what they do well and why they carry certain limits and risks. This image shows the 5 stages that occur every time you submit a prompt and receive a response. Starting with your input, then tokenization, context processing, probability estimation, and iterative generation. Understanding these stages will help you use these tools more effectively and more responsibly. Everything begins with what you give the model, your prompt. Your question, instruction, or request is the starting point for everything that follows. And it is important to understand what the model actually works with. It works only with the text that is currently in front of it. The model has no memory of past conversations unless that information is explicitly included. It does not know your clinical background, your specialty, your patient population, or the context behind your question, unless you tell it. Think of it like a highly capable consultant who has never met you, has no access to your records, and is working only from what you hand them in the room. Now, this means the quality of what you get back is directly tied to the quality of what you put in. A vague prompt produces a vague response. A poorly framed question can produce a confident-sounding but misleading answer. The model is not filling in what you left unsaid. It is responding to exactly what is there. Once you submit a prompt, the model breaks your input into smaller units called tokens. A token can be a whole word, part of a word, or a punctuation mark. Each token is then converted into a number because computers process information mathematically, not linguistically. Now, this matters for clinicians and healthcare leaders because your carefully chosen language, precise terminology, clinical context, nuanced phrasing gets broken down and converted before the model processes a single word. The model is not reading your input the way a colleague would. It is working with a mathematical representation of it. In any context where precision matters, that distinction is worth keeping in mind. After tokenization, the model processes the full conversation through multiple internal layers. Think of this as a system analyzing how every word in your input relates to every other word at the same time. It uses what it learned during training to build its best approximation of what your input means. Now, this is not comprehension. There is no understanding happening here. The model is identifying statistical relationships between words, patterns it has seen before in its training data. It is doing this very quickly in a very sophisticated process, but it is pattern recognition, not reasoning. There is also no live lookup happening. The model is not searching the internet unless you explicitly allow it to. It's not consulting clinical guidelines or checking the latest research in real time. It is working entirely from a fixed snapshot of what it learned during training, which has a cutoff date and reflects whatever was and was not in the data it was trained on. After processing your input, the model does something very specific. It calculates the probability of every possible next word, and these systems can work with vocabularies of tens of thousands of words and word fragments. It then selects the word that is statistically most likely to come next, given everything it has just processed. Now, notice what the model is doing here. It is calculating likelihood, not truth, not accuracy, not clinical appropriateness. It is asking, given these words in this order, what word tends to follow in situations like this one? This is where the most important distinction lives. The model can produce a response that sounds authoritative, well-structured, and clinically grounded, because generating fluent, plausible language is exactly what it is optimized for. But fluency is not the same as accuracy. A fluent response can be incomplete, outdated, or simply wrong, and the model has no built-in mechanism to know the difference. Once the model selects a word, it adds that word to the sequence and repeats the entire process. Context processing, probability estimation, word selection, again and again and again. One word at a time until the response is complete. That means the response you receive was not retrieved from a database. It was not written all at once. It was built step by step, one word at a time, each step based on the probabilities calculated from everything that came before. And because each step is probability-based, fluent language can be produced even when the underlying information is incomplete, outdated, or incorrect. The model does not stop when it reaches the edge of what it knows. It does not flag uncertainty or ask for clarification. It keeps generating because that is the mechanism. That is what it was built to do. Let's make this concrete. Suppose someone enters the following into a prompt box. In therapy, the most important factor for positive outcomes is... Many of you are already predicting what comes next. You might be thinking the therapeutic alliance. Your clinical training is doing something predictive. That is essentially what the model is doing, but without any of that training or understanding behind it. It takes the words so far and calculates which word is statistically most likely to come next based on patterns in its training data. It selects the. Now the sentence reads, in therapy, the most important factor for positive outcomes is the. It repeats the process and you get therapeutic. Then again, and you get alliance. Until eventually the response becomes, in therapy, the most important factor for positive outcomes is the therapeutic alliance. That sounds informed. It may even be correct, but the model did not reason its way there. It did not consult the research literature. It calculated probabilities, one word at a time. Now change the prompt slightly. In therapy, the most important factor for positive outcomes is lavender aromatherapy end. The model will continue confidently, perhaps describing relaxation benefits, stress reduction, or sensory grounding. It will not stop and say the premise is questionable. It will not flag a lack of clinical evidence. Its job is to produce a coherent continuation, and it will do that regardless of whether the starting premise is sound. This is not a hypothetical risk. Patients and staff are already arriving with AI-generated information in hand, sometimes accurate, sometimes not, and with full confidence in what they read. Understanding why that happens is the first step towards addressing it effectively. Now, across all 5 stages, one thing remains consistent. These systems are powerful because they generate language that closely resembles informed human communication. But that resemblance comes from statistical pattern matching, not reasoning, not clinical judgment, and not an understanding of your patient population, your organization, or your context. Nothing about how these models generate responses gives them the ability to verify truth, recognize their own errors, or take responsibility for outcomes. Their usefulness and their risks always go together. Using AI well in healthcare means understanding that fluency is not a proxy for accuracy, and that every time you act on an AI-generated response, the professional judgment and the accountability remains with you. What we know about how these systems respond should guide how we use them, as a supporting tool, not a substitute for clinical judgment.